Good evening, everyone. Welcome to another episode of weekly webinar session from Yashoda Hospitals, Hyderabad. Every week, we bring in latest topics in the field of emergency medicine. This week, we have our speaker, Professor M. Dato, Dr. Rishya Manikam. He has done his MBBS from India. Then later on, he went on to the University of Malaya, where he has done MEmMed. Now, he'll be speaking on the topic of what we do in and why we do in the ED. It's not just confined to one or two topics. He'll be speaking on core emergencies that are dealt in every ED. So welcome, Doctor, to the webinar episode. Please, you can start sharing the screen.
Thank you, Dr. Naveen. I will share the screen. Are you able to see the screen? Are you able to see the screen that I'm sharing, Dr. Naveen and others?
Not yet, but let me check.
Okay.
Pawan, can you confirm?
Yes, sir. Screen is not visible.
Visible?
1 minute. Sir, presentation is not visible, sir.
Presentation not visible. Huh? Okay. Let me just, I'm actually sharing it. I'll share it once again. Screen. Is it visible now?
Yes, sir, it's visible now.
Okay. Okay. Good evening, everyone. Good evening, Dr. Naveen. Good evening, the technical committee and everyone who is here. Shall we start?
Yes, sir, good to go.
Wonderful. Thank you for taking time to join us this Friday evening. I would like to say thanks to Dr. Naveen, of course, Dr. Srinath, who reached out to me. It's always nice to be back with Semi, and thank you, Yashoda Hospitals, for making this possible. We being in ED on a daily basis, we see patients, we treat patients, we want to stabilize them, we want to optimize them. After doing this for a long period, sometimes you wonder, does the thing really gets complex on a daily basis? Or is there something that that is a frame, that is something that we are sometimes missing, or we are going away from the fundamentals that what we are doing? And after running the master's program here, and I would say producing almost up to 40% of the emergency physicians in the country went through me in the university, and a reasonable amount of number now around the country and around the world. And I realize sometimes it's the core fundamentals that we derail, we miss, and that lands up in trouble for our patients, our beloved patients. So I'm going to just be very casual and I'm going to just share a couple of scenarios which for some of you who are already understanding that and doing that, practicing that, it's good. But if you think that it's an aha movement, that yes, I've been in this situation before, but that was not my thinking process. And then that's something which we can work on it, and we can work on it. So let me start with the first one. I gave this topic, why we do what we do. It's because sometimes we are not sure why we do what we do. We do because things are automated. Things have been expected us to do. That's how our referral team wants us to do. That's what our previous seniors taught us what to do. So we end up doing. So after having some amount of maturity, after spending reasonably about 20 over years in the emergency department, working through the system, now I get some clarity, starting to get some clarity to see why actually we do this. And that's what I wanted to share some things with you. If you can look at the photo, you clearly see one of the thighs is swelled up, and naturally, If the history towards a fall, then you would want to consider, is there a femur fracture? You are right. If you think it's a femur fracture, yes, it's a femur fracture. As you can see, the fracture, simple, straightforward, no issue. What do? Immobilize the patient, pain, first aid, get to appropriate team, and we start thinking of all the algorithms which are taught to us, whether it's a displaced fracture or undisplaced fracture, what do we do, and so on. And the next level discussion, we think we get a lot more deeper, the types of fracture, the types of fixation. We are talking about the following discussion. Sometimes we go deeper into whether it's an interlocking nail, it's something suitable for this patient, or plating, or external fixator, or whatever the specifications which this patient. So we are going deeper and deeper. If you can see, from a swelling fracture, then we are going deeper into the classifications, deeper into the treatment modes. Yeah. That's where the question comes, why we do what we do. And the catchphrase is in ED, in ED. So let me bring you back to this X-ray. This is a femur fracture, which you can see, and you can see the normal femur and the femur fracture. Look at it, take some time to look at it. Now, if you can see, it is a cylindrical. Now with the fracture, the shadows are already showing you there's a sphere there. If you can superimpose, that's how it looks like. Now, why is this important? That's important. That's because you need to do traction. And this is very fundamental. Why fundamental? Because many a times, at least the places that I've been, and many a times, most places, they don't do the simple traction. And now why do we need this traction? That's because all you want to do is, we are trying to actually convert the sphere into a cylinder. So if you really look at it carefully, when it is cylinder, the volume it can have is to square root of, it's actually r square 2 of the radius. Whereas when we convert, if there is a fracture femur and that converts to a sphere, and now the volume which can accumulate becomes r to power of 3. So what a simple diameter of, let's say, 2 centimeter can give a volume of 4 liters. The same radius of a 2 now can accommodate 2 to power of 3. That becomes a lot more than just a simple 4. So 2 times 2 times 2, you can see the amount of volume it can accommodate. So when you actually seeing a patient with fracture femur, our aim is deeper and deeper into pain, immobilization, getting X-ray, getting to orthopedics, getting to name the fracture types, and then getting to treatment plan. But what's happening in ED is actually the patient is continuously losing blood. And why I take this seriously? Because in many institutions, the time patients spend in ED is considerably long, reasonable amount of time, significant amount of time they spend with us in ED. Could be anything ranging between 4 hours, 8 hours, 12 hours. Sometimes they may stay until the patient is called into OT. And fracture femur, a stable closed fracture femur, is the type of a fracture which never gets listed quickly if it is in a very busy hospital. So it will be operated after the emergencies, like the hospitals where I work with. It's a trauma center with all specialty there with 2,000 beds. So in that manner, getting an OT time and fixing this, it's not going to happen anytime soon. especially if it is a closed fracture. But if you do not consider converting this sphere into a cylinder bag, now we are allowing the patient to actually bleed and bleed. And we have had patients lost a reasonable amount of fluid before we could detect. So now, if you intervene early, that means as the patient comes in, we get to this concept. If there is a femur fracture, quickly convert the sphere into a cylinder. Now, by means of putting a traction, you can see a head traction there. And that will definitely help in that. That's the first observation. So let's move on to the second one, a seizure. Somebody comes in fitting, very commonly seen. Somebody comes in fitting, they've been rushed to the emergency and in the triage, they will be pushed straight to our red zone. Fitting, yes, first aim is to get to the triage and try to abort the seizure. And now, left lateral, suction, oxygen, rectal diazepam, or if there is a line, get some medication in, first trying to avoid the seizure, abort the seizure. If the patient continues to fit, then you immediately get into the guidelines that we have. I've just put in some of the guidelines which I picked it up. It depends on what you are using in individual hospitals or setup. So let's say a patient continue to fit. What do? You of course manage the ABCD airway, secure the airway, get the access, and do whatever necessary to abort the fit. You give the first layer, first line medications. Then the patient continues to fit. That's where you go into a second layer medication, second line of medication. That's where phenytoin comes in. Now, so far, I'm sure you are following me. Somebody comes in fitting, push into red zone, and you are trying to avoid the fit and still fitting after the first securing ABCD, getting the medication, still fitting. Now phenytoin goes in, and you go into the discussion whether you want to use phenytoin, phosphatidylcholine, what kind of medication, what you are doing, and things like that. Now that's where the question comes. Why we do what we do in ED? Now, the question I want to ask everyone here is, how do you know that the patient is not fitting due to phenytoin toxicity? Is that ever been a question that comes into your mind? Because time and time, I've seen patient receiving phenytoin on a very default mode. If someone fits, they give the first line drug. If continues to fit, they get phenytoin. When I ask why phenytoin is given, then it is the answer of the guidelines says the second line and goes on. Now, I have personally picked up 4 patients who fitted due to phenytoin toxicity in a short period of time and avoided phenytoin. Now, I want to take back this message. Actually, patient who is having phenytoin toxicity can actually fit. And because we were not doing what we supposed to do when we didn't know what we were doing, and we were so automated, patient actually goes into a lot more unwell status, go into coma. So the question is, again, it is not just following the guideline, but stop and ask, what do I do and why do I do it in ED? So what stops me from not giving the phenytoin and thought of phenytoin toxicity? Because I asked myself, why am I giving phenytoin? So it is not an automated default process. And that's the second case that I want to tell. The third, very commonly seen, we use this very common, we see this very common, an elderly fall, You see this very common, and in many countries, this is becoming a huge admission burden to the hospitals as the population is aging, and you see more and more of such incidents, and a lot more of our elderly populations are being independent now, many of them staying alone. So the risk of a fall is also tremendously increasing. Of course, availability of a healthcare. Previously, what was considered as old when they were reaching 60, 65, 70, now it is already a new beginning. So people at 80, 90, and 95 are still actively driving among many of our areas where we reside. So they become our patient. Well, if somebody falls, naturally we are looking at elderly fall. It's either a question of neck or femur fracture, intertrochanteric fracture, or you can even have a subtrochanteric fracture. So now we are discussing into patient brought in fall, elderly. And now we are talking about there's some limb discrepancy, there's some discomfort, there's some pain over the hip. Now we say, what kind of fracture? The discussion goes into what kind of a fracture and what are the classification of the fracture. Let's do an X-ray. Let's do a mobilization. So we are into that discussion. Next question. Many of the organization now already have a hip fracture unit where they already have a plan what to do, what gets triggered as a patient comes in with a hip fracture. In fact, in our facility, we run a study called hip attack, where somebody comes in with a hip fracture. We immediately activate the system, and like a trauma activation, like a stroke activation, like a cardiac ACS MI activation, STEMI network, like that, we do have a hip attack kind of a unit. Yes, it gets activated, X-rays are taken, admitted, planned for surgery, post-surgery rehabilitation. So a lot of discussion goes into entire thing. Being in ED, even our residents and our doctors discuss about it because it's part and parcel of the treatment. Now, the next question is prophylaxis in these patients. Now, these are elderly patients. Sometimes they may be on warfarin or aspirin or Plavix due to their cardiovascular diseases that need to be stopped for surgery, and maybe you need to overlap with some of the thromboprophylaxis. Or sometimes, as they are going to be immobilized, you will be thinking of thromboprophylaxis. And very commonly, thromboprophylaxis has been started in ED itself, sometimes by the colleagues from orthopedics. They start that. We see this in our setup. And in fact, our trainees, our doctors are also embarking proactively and quickly starting the prophylaxis right from the ED. Of course, discussion comes into, you want to avoid a DVT. And of course, with that comes medical, non-medical treatment type of, care for the DVT prophylaxis. In that, discussion goes on to heparin, whether you want to use a Claxine, you want to use what kind of medication you want to use. And of course, detail goes into, in fact, some of the detailed discussion, people discuss about the pros and cons, and then the content of it, halal and haram, whether it contains what kind of substance, and then the dose and the monitoring of it. This all goes into discussion, so much so some of them even go into discussions into the molecular level. Now, my question is, regularly we hear this. The moment you start that, patient get confused, fitted, and intubated. Why? And that's where we need to know why we do what we do. In ED, again, I'm telling this word, in ED. Now, what happens is when a patient sustains a fall, especially an elderly person, the only question I ask when I come to do rounds, when I see a patient, an elderly patient, any patients, but especially an elderly patient when this come into ED with a fracture, I ask this particular question. Is this a mechanical fall or non-mechanical fall? Why is this question important? Take some time to think of it. I only ask this question. Is this a mechanical fall or non-mechanical fall? That's where my starting point is. Why? Because what is a mechanical fall? Patient slipped and fell. Patient got up into the chair, and then while trying to take a box, the chair leg broke and fell. Patient was walking into the toilet, slipped and fell. It was a wet floor, slipped and fell. The domestic pets, dog were chasing, and they were playing and suddenly jumped on them, and then they had a fall. Or they missed a step and had a fall. So any of this, very clear, mechanical. Now, when I ask a question mechanical, now that's where it triggers the most important part, which is the non-mechanical part of it. What is the non-mechanical part of it? Why did they fall? We all take it very lightly. I sometimes see even my residents at times, even especially sometimes, take things very lightly when it comes to fall. And they tell me, a patient fall on the way to fall out of the bed, Prof, fell while going to the toilet. So now my question is this patient fall while getting out of the bed in a different bed, or is the same bed as what they were sleeping all this while? Have they gone somewhere visiting? It's in a new place, so they have an adjustment problem and they had a fall, or is this the same bed and they had a fall? Why didn't the slip or fall happen yesterday, and why it happened today? So did this patient actually have a mild stroke? Did this patient have a mild stroke? So why I asked this, the patient I put up after they started the thromboprophylaxis, Claxin was given. Later patient deteriorated, fitted, and we had to intubate. CT brain shows a bleed. So patient actually had a hemorrhagic stroke. And because a simple, what we're supposed to do in ED, which is ascertain this whether mechanical or non-mechanical, if we have asked that question, we could have prevented or at least triggered us to examine the patient, especially during this period of COVID, where everybody is wearing masks. Now, when we retrospectively looked at this patient actually had a facial palsy. So there are some telltale signs sometimes we miss just because we don't ask the exact question. And that question need to be asked every time you want to intervene or you want to do something. And that's what the question comes. The question, what we do and why we do what we do. So you must understand every time you do something, and that's going to get some implication to patient. So comes to the other discussion, GCS. I'm sure you know GCS. I'm sure you are an expert in GCS. I'm sure you use GCS, Glasgow Coma Scale, modified, different for adult, for children in a very, very specific manner. A scenario where a patient is brought in to ED, where you are working with the staff shouting GCS 6/15. GCS 6/15. Now, the moment you hear GCS 6/15, What's running into your mind? Surely, intubate versus what methods that I want to use. Intubate, prepare for intubation, intubation. And then, of course, assessing the patient, what kind of intubation, whether suitable for, it's a simple intubation or it's a difficult intubation, and whether you need any help, whether you need logistic help, manpower help, or video assisted help, or discussion goes into that method. And of course, all the steps of preparation towards there and all the care. So that's goes in for this patient. Now, why we do what we do again in ED? I keep repeating this slide. That's because in this patient, this is an important question. Somebody shouted GCS 6/15. Now our brain tuned towards GCS 6/15. That means below 7, 8. Now patient cannot protect the airway, intubation. But remember, GCS is part of D. And who actually did the D? I said staff. Many a times a patient pushed into our resus with people shouting loosely about the GCS. It can be an outside ambulance which is sending a patient, or some people who are sending the patient towards us, and with their level of whatever understanding of GCS, many a times the scoring of a GCS, which is say sometimes it may not be tallying with the exact GCS. So in this patient, you know GCS comes under D. But while you are busy intubating the patient because the GCS is 6, and for all of the colleagues who are listening to the talk, you know how not instant that preparation for intubation happens, right? So sometimes while you are busy, sometimes while we are busy in intubating, securing the airway, we actually missed out on the ABCD, like in this patient. You have a tension pneumothorax, that you have a tamponade. So this is a real scenario where we have had patients deteriorate because there were people who were keen on addressing the GCS, which is part of D. You might be saying, this is fundamental of emergency medicine, Prof. This is fundamental. But we must do ABCD first, then only we go to D. Yes, why do you think I actually pick up and talking about it? I'm reasonably senior enough to talk about topics. Why would I want to talk something as simple as this? Because we are realizing that people are going too deep, too technical, and they actually, at the time when it is needed, they actually get hooked on to the specific technical aspect and then travel from then onwards. So you need to come out of the tunnel. You need to ask a question. What is best for the patient? And why do I do what do I do? And why do I actually do this? So if you're going to intubate the patient, the first thing is, okay, airway okay? Have I cleared? Have I cleared the airway? No. Did I do an airway assessment? Quickly do an airway assessment. Have I done a quick breathing assessment? Have I done the C? Have I, if you have not done that, now we have, how many of us actually put our fingers into the trachea and looking into the trachea and assess the trachea? So sometimes very fundamental, we are already holding on to the ultrasound probe, putting and seeing if there is a seashore sign, if there is a B lines or A lines, if there is a signs of pneumothorax. We are already going towards there. So it's a tool which can tell us quickly an answer, but then we are actually acting on the technical aspects of it rather than seeing what is benefit for the patient. So that comes to the question all the time I ask in ED. Why do we do what do we do? Because many a times we think as we grow, we need to accumulate a lot more technical aspect. But actually, as we are growing, we need to make sure we stick to the fundamentals, and then we ask ourselves why we do this. Why we actually do this? Because that gives us a clarity in terms of why actually we choose this. So I wanted to make this simple because along the way, I have noticed the simple things like what I've said just now was just overlooked purely because they were very interested in a technical aspect. I see people are busy fighting over what size of ET tube to be used rather than whether can we just settle the airway breathing while this patient still having pneumothorax. We are still talking about intubation when the patient do not have a airway issue. So you're intubating for the D, which is the GCS, unable to protect the airway, but you're not addressing the B where the pneumothorax is there. So the cases that I put up is actually the real cases that happens in our EDs on a day-to-day basis. So open up your eyes for the leaders of the emergency medicine. Help them to declutter all the technical aspect and rope them into a logical way of looking at this. And I suppose these are some of the examples that I picked up purely because we have avoided ever since we get our trainees, get our residents, get our doctors, and including me, remind myself. I keep reminding myself every time I see a patient, why do I do? What do I, what we do? Why do I do what we do in ED? And I'm very specific with the word in ED because we get diluted and we will go into the areas of what happens next. We need to get here, sort these things, and that will help us. As I'm speaking, I will also tell about an ECG finding. We regularly fight over the ECG finding, whether there is an LBB or fascicular block or left fascicular block, right fascicular block, whether there's an RBB, whether there's a new LBB, or whether there is you do the scoring and then you say whether the scabosa is okay or what kind of type of this. And then we end up arguing with the other colleagues or other colleagues from other departments, and we try to establish the ECG point of it. I asked very easy question. ECG in electrical pattern. Is that electrical pattern is life-threatening, which is the shockable rhythm? Or if it is non-shockable rhythm, patient is awake, whether brady or tachy, whether it's stable or unstable. If it is unstable, there is a generic treatment to it. When it is stable, we have some time, there are some specific treatment you can give. See whether the electrical pattern is causing trouble. Next, mechanically, if this patient heart is functioning, whether there's a tension pneumothorax, whether there is any regional abnormality, there is a massive global issues in the contractility, or if there is a leak, or if there is an aneurysm, or if you look into the aorta. I'm sure as I'm speaking, all of you here are practicing a quick ultrasound, a quick echo, a dynamic ones to our patient's assessment. So I always say whether the electrical pattern and the mechanical pattern is jiving together, and is that giving out to the functional, which is the BP, heart rate, and the other functional value, and the perfusion to the important organs are being maintained. If those are all working together, we do have some time to discuss about the specific electrical pattern, get to the expert and talk to them. So don't fight over the electrical pattern and you miss out on the issues which is really happening to this patient. So now ask your question, why do we do what we do? When the patient comes to us in ED, manage the patient as a whole, not just look into the ECG and fight it over. So whatever I'm trying to say is based on the experience that I've gone through. I was thinking that as I was getting senior, I'm going to get more specific and more, looking into things in a very deeper manner, more scrutinized manner. But then realized when we actually ask ourselves why we do what we do, and specifically in ED, specifically what I do and why I do this, and then things becomes clear, and I no longer have this arguments which is not needed for the ED management. So declutter all the things which is not relevant to us, get the fundamentals correct, ask yourself this question regularly, ask yourself this question regularly, as regular as how many times I have said it during this presentation. And that will give you a clarity. And I'm only interested in, making you have some clarity and not the technical aspect that we are talking about. So I think I have repeated the word why we do what we do many times today, until so much so that you might get stuck to that word. And I hope I made my point reasonably simple and clear, because extraordinary means you're being extraordinary. If you can see the things extraordinarily, that means extra simple, then you will get to provide a good care. With that, I'll pass you back to Dr. Naveen to coordinate. Dr. Naveen?
Yes, sir. So if you guys have any questions, you may post in the chat box or you can use the QA section. So as of now, we have one question, that is, what is the difference between phenytoin and phosphenytoin?
Okay, so, as you can, okay, sorry.
I think it was addressed in one of the slides.
Yes, I'm going to put back that I'll share this. Well, again, to the gentleman who have asked the question, okay, I hope you can see. I'm putting this here. Okay, that's a slide. Okay.
Yeah, this one.
So, yeah, so again, to the gentleman who asked the question, this is again my area, but I don't want to discuss about the technical aspect of the topic between phenytoin and phosphenytoin. You see whether it's available in your place, and then check it out and talk to the people who you are working with, or what's available with you. But that's not the point that I want you to take between phenytoin and phosphenytoin. But the point I wanted the audience to take back today is, please do not give phenytoin in a patient who is fitting when he's fitting from phenytoin toxicity. The question is, you must think of phenytoin toxicity when someone is fitting. So it is not by default. So that's why what you do, you need to have the thinking process. Otherwise, you will end up landing this patient into a deeper trouble just because phenytoin was used. So it's not a question about phenytoin or phosphophenytoin. It's a question about whether you thought of phenytoin toxicity at the time somebody is fitting. Can you imagine if somebody having a, let me give you another example. Another great example which I faced in one of my practice is, someone came with anaphylactic shock and the person is actually allergic to adrenaline and hydrocodone. would you think to ever even think of asking someone who comes in with an anaphylaxis that they will be allergic to hydrocodone or adrenaline? We won't think of that. Why? Because this is the treatment and you will not be wrong if you are giving it. But this person actually is allergic to these two medications. And I've had a situation like that. I've had a patient who actually develops anaphylaxis and in fact to a area where he collapsed and needed intubation when he was given PCN. And now this guy comes in to the hospital with high fever. And he don't remember the medication's name. So things like this do happen regularly. And you will be surprised to see that before every intervention, if you ask the question which I've been repeating, and then it might give you a small gap before you move on to the next one, which is, okay, I need to give adrenaline for this patient. Now, first question, is he allergic to adrenaline? Are you allergic to adrenaline? Or can you get that information? Because if someone is allergic to some medication, they will tell. Sometimes they may not know if the context is correct. Now, so it's our job to make it to that context. Yeah. So look into the slide that I've put in, and you can actually get the answers discussed with the team where you are working. Okay.
Okay, it looks like there are no more questions. Thank you very much for the interesting topic, Doctor. So even the phenytoin toxicity related seizures, that's something that's missed very often, that you have stressed upon many times.
Yes.
And the elderly population gets ignored at every ED, I can say. Okay, thank you so much.
Thank you so much, Dr. Naveen, and the entire team and a wonderful participant. I have a huge number of collections of, in fact, we are compiling and making a book, a huge number of collections of such simple things being missed out. As you can say, I can see that, you see, Dr. Naveen, at your level, at a senior level, you are feeling what I'm saying.
Exactly.
The problem is our boys are still, that's what, if you can see the behind my, if you can see the screen behind Dunning-Kruger's, I always use this. When we don't know what we don't know, we have highest of the confidence. And when we get to know what we don't know, then we start learning. Hopefully we get to know what we know. And one day when we are reasonably senior enough, we may not know what we know. So at least let's embark in the journey. So I'm very, 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 I'm very interested in making sure that we tell people what, at least create the people who don't know what they don't know to a level where get to know what they don't know, then at least they are in the correct path. So the seniors will understand what I'm saying. And that's what I start embarking into such talks. I hope our beloved residents and everybody else pick this up. And as you said, regularly, it's been practiced and missed here. Thank you, Dr. Naveen.
Okay. People can catch up about our weekly webinars on one of our Telegram channels, that is telegram.me/med_peat. So every week we'll be posting the upcoming schedules on this Telegram channel. Thank you so much, Doctor. We'll be ending the session now.
Thank you, Dr. Naveen. Please send my regards to Dr. Srinath. Thank you.
Sure, sir.